Hello, everyone. We'll start in just a couple minutes. Hello, thanks for joining us today. My name is David Willis, Senior Fellow with the Center for the Study of Social Policy, and I'm the founder of Nurture Connection, a network of networks to promote early relational health. Today, we're going to take a deep look at Nurture Connection's State Leadership and Policy Action to Advance Early Relational Health report and provide an overview of our early relational health policy agenda and a summary of recent state policy actions. You can find the link to the State Leadership Report in the chat. As the founder of Nurture Connection, I'm pleased to share that we just reached our first year of network building with immense growth. Nurture Connection is a network of networks promoting strong, positive, and nurturing early relationships to build healthier and more connected communities. And as we do this, we engage a variety of voices and expertise, from parents and caregivers to doctors and doulas, to policymakers and researchers, all on early relational health. That is the state of emotional well-being that grows from positive connections between babies and their parents, caregivers, and the surrounding community. Advancing policy is one of our 6 core strategies, as we recognize that public policy and social structures have a huge impact on the well-being of families. No family succeeds on their own, and many face challenges that only policy can actually address. You will hear more about one of our reports today, and in addition, we will post other resources in the chat. To give you a preview of today's webinar, first you'll get to hear a presentation from Kay Johnson, co-author of the State Leadership Report and nationally recognized long-term MCH policy analyst. We will then open up discussion between our ERH policy team members, Karen Howard, who's with Crossover Partners, Elisabeth Wright Burak, who's at Georgetown University, and Geoff Nagle of Tulane University. I'm really pleased to introduce you to Kay Johnson, one of my dear friends and co-authors of Nurture Connection, State Policy and Leadership Action from Early Relational Health. Let me say that again. Author of our Nurture Connections, State Leadership and Policy Action to Advance Early Relational Health. Kay Johnson has become nationally recognized for her work in maternal and child health as a policy analyst, an advocate, and a consultant with over 40 years of great leadership. Reducing the impact of poverty and racism and increasing access to services for women, children, and their families has been 2 of her lifelong goals. Kay has been active in Medicaid and EPSDT at the federal and state levels and has served as consultant advisor to more than 45 states regarding health policy. Currently, Kay is a senior member of and a consultant to our Nurture Connection policy team. So Kay, to you.
Thank you, David. It's really my pleasure to be with you here today. And I'm going to start sharing my slides, and really am delighted to have an opportunity to talk about this work and to talk to you some of what we've been doing and focusing on. I'm going to turn off my video so that you can actually focus on what the slides have to say. So let's begin by thinking about the policy team. I just want to acknowledge that the work that I'm presenting is from a Nurture Connection ERH policy team with Dr. Willis leads. Elisabeth Burak, Karen Howard, and Geoff Nagle are on with us today, but our team in 22 and 23 also included Shadi Hushar, Dana Long, and Hoda Shaki, whose work you'll be seeing in other pieces. As David's mentioned, the idea of promoting early relational health is at the essence of the Nurture Connection network and strategies. And we have multiple strategies for promoting strong, positive, nurturing early relationships that are guided by families, designed to build healthier, more connected communities, and to have well-being be at the center of our families' lives. And what we know, for too long, our nation has perpetuated economic, health, human services, and early childhood policies that do not promote and support foundational early relationships between parents and young children. They're often punitive, or they have cliffs, or they create additional stress on families rather than support them. And we know that structural racism, poverty, and other systemic inequities have impact on the lives of families with young children that deepen disparities and threaten positive outcomes. Young children are the poorest population group in America. Young children are more likely to be of color, and they and their families to face the barriers posed by structural and institutional racism. And young children are the most likely to live in socially isolated, disinvested, concentrated poverty communities. So in order to get to more being families, public policy changes are clearly our policy headlines of our policy goals. This is our agenda, and it really is grounded in the fact that we think that all policies should aim to advance equity, that families need greater support for economic security, and that might be on child tax credits or other income and perhaps nutritional supports, that providers need training about early relational health and the principles of early relational health. And by that, we think of pediatricians and doulas and community health workers and mental health workers and child welfare workers, an array of providers that could be grounding their work to more support families in these early relationships. There's an array of evidence-informed program models and services that can promote early relational health. We know what these are. While more research is going on, we have a good menu of those already, and they could be spread and scaled. We believe that a relational workforce is fundamental to getting this done, and that would include people like community health workers and are able to connect providers, families, and communities. And to have high-performing medical homes, which would be pediatric primary care settings that are team-based, that have a relational care coordination approach, and that embed models that are intended to support child health and development in the early years, such as Healthy Steps and Dulce and VIP. And that the parent, infant, early childhood mental health service system is fundamental to getting this work done as well. And we have a growing workforce there and who can also be helping to get the job done of early relational health. Thinking about the overall community, the early childhood systems approach, where home visiting and child welfare and other networks of providers are coming in to build a community-wide approach that supports families in all the ways that we know they need in the early years of life. I like to think of this as there being this whole array of providers, whether it's pediatricians or infant mental health workers or home visitors or doulas. They all see their role as providing support for the health and well-being of families with young children. If they're all working together to promote early relational health, think of the impact we could have. But we know that our current federal policy leaves gaps, and it gives states broad authority to take action to support families. So we undertook a study of state leadership and policy action to advance early relational health, building off of examples that David and I knew well in states or that we'd heard about and the people we'd been working with. And Geoff joined us in this work in order to do a lot of interviewing and really getting into the details of what states are doing. We're really pleased with the report, and it takes two angles. The first is that we looked across 50 states about what they are doing, what policies they're adopting that could promote early relational health. And I just want to say, we're not about one bill You could see that from our agenda. Something doesn't have to be called early relational health to be part of our agenda, clearly. And you can see we made sort of 4 bundles out of elements of the agenda. So the first in economic security and equity, and I'm not going to read all of these, but you see they're about paid family leave and minimum wage and tax credits and SNAP food nutrition support. So around parent, infant, childhood mental health, we've selected 3 recommended screenings that would help get families to additional referrals and connections to services that they need. We looked then at a bundle that's high-performing medical homes, workforce, and services to promote early relational health. And you can see 3 of these are about Medicaid financing, and the other 2 are about programs such as those that are around development and connection, like Healthy Steps and Dulce, and things like group prenatal care. And last but not least, what are states doing in the context of early childhood systems development and transformation of pediatrics for early childhood? What you don't see on this list, and maybe you're wondering, where's my thing? I'm just going to use an example. Visiting here, because every state has federal dollars for home visiting. So those things are not here. These are things where we think states could do improvement. A lot of them we've drawn from the roadmap developed by the Prenatal to 3 Policy Impact Center, and we're grateful to them for their support and engagement intellectually with us in this work. And we've used elements from other entities and organizations you can see below. I'm going to just show you a couple of maps that highlight really some of these findings. This one, the green, is the state refundable earned income tax credits and non-refundable earned income tax credits in the lighter green, and the stars are states that have paid family leave. You can see the paid family leave is pretty scarce, and the EITC is not everywhere. And we know the map would look similar with child tax credits, and that having Congress continue the child tax credit is an opportunity that still remains ahead of us. I know Karen's going to talk more about that later. Here's a map that looks at the finance policies. So from the Kaiser Family Foundation tracker of postpartum coverage, you can see 44 states, including DC, have already implemented the extension. There are 3 in green that are still really just finishing up in their implementation, 1 with a limited proposal, and only 3 states that have failed to take action on this. And what we know is that if every state extended Medicaid postpartum coverage to 12 months, 2 million mother-baby pairs would have a full year of continuous health coverage to finance services that promote early relational health and well-being. The red stars on the map are those that have Medicaid financing for doulas. Some of them are in the very early implementation stages of this, but it is a growing movement that should be spread farther. In terms of health coverage for young children, the bad news is that 3.5 million children have lost coverage under the Medicaid unwinding post-COVID public health emergency. And if you want to follow that story, the Georgetown Center for Children and Family has a tracker for that. And the good news, also followed by Georgetown, is that 12 states are seeking to provide continuous coverage for young children that reaches beyond that 1 year of guaranteed coverage for infants and the extension of postpartum coverage for mothers. And you can see those 12 states, dark blue implementing and lighter blue in development. This is an opportunity perhaps your state could take advantage of. This map shows you the Medicaid coverage of social determinants of health screening. Only 4 states reported that they provided supplemental payment for social determinants of health screening of young children and their families last year. And the others say they included it in the payment for well child, but not reported that they do not reimburse for social determinant of health screening for young children. This is recommended by the American Academy of Pediatrics. It should be part of well child visits. And yet we can clearly see that that not every state is doing it. You'll see in some states there is a square icon that represents states that require or recommend the use of a standardized tool for social determinant screening. And again, that would be recommended by the American Academy of Pediatrics. So in addition to that 50-state look, we took a detailed look at 6 states and featured sort of mini case studies about them. I would say the broadest, and you can see these are not in alphabetic order, we sort of picked them to highlight different facets of our agenda, and New Jersey's in some ways doing it all. They've got a broad initiative to promote early relational health. They're using the term early relational health. They're aiming to strengthen systems, and they're working in a cross-systems approach. They're also explicitly aiming to advance equity, beginning prenatally and focusing on the mothers and the babies, and then the early childhood years and the collection of early childhood systems. In Oregon, they're using measurement to drive healthcare system innovation for children at risk, not just children at medical risk with chronic conditions, but also those with social risk. In Washington, they're improving early relational health and infant early childhood mental health through public-private partnerships, in particular, having a strong team built into their Medicaid agency with that focus. Washington also has a demonstration project that is putting community health workers into pediatric primary care to promote early relational health. In California, the past 2 or 3 years, they've been moving upstream to finance services that can promote early relational health and well-being with Medicaid. So community health workers, doulas, pediatric primary care with embedded models such as Healthy Steps, as well as sort of an overhaul of their regulation of the Medicaid child EPSDT benefit. In Michigan, they're developing provider training and workforce competencies related to early relational health, really in some ways beginning on the mental health side. And in Vermont, they've been accelerating early relational health through team-based high-performing medical homes with Dulce. For each of these states, you'll see a variety of things they're doing across our agenda, but these are the reasons that we went to showcase their particular work. What did we learn looking at those 6 states? A focus on cross-systems change is really important, that public-private partnerships are the essence of what's going on that's driving change in each of them, that families are engaged in leadership, and in many ways, some of these initiatives are particularly community grounded, that the issue of workforce training around early relational health has growing momentum in some of these states, that they've given a priority on prevention and promotion of well-being rather than just waiting to treat the problems. They're using data to drive change and focus on outcomes improvement, that for some of them, they have an explicit focus on equity and cultural safety, and we need more of that. And many of you have heard me speak before about spending smarter, which means using all of your resources in the most effective manner, not saying Medicaid can do it all, or public health can do it all, or philanthropy can do it all. And in fact, in every case, the public and private funding played a role in the success of what's happened in each of these states. We believe that every state can better leverage their income, health, mental health, early care and education, child welfare, and other policies and programs that serve families with young children. There is an opportunity you can see in our 50-state table for improvement in virtually every state with one or more policy changes. There policies that have shown to be effective, and we know that can make a difference for the young children and their development and the well-being of the family. We believe that now's the time to partner with families, providers, and communities to advance equity and strengthen early relational health through effective policy advocacy and implementation. I'm particularly implementation of the postpartum coverage extension. I think it's not enough to say we got new mothers coverage. I think we have to figure out how to leverage that coverage into meaningful services that save lives and promote their well-being. We can reimagine and co-design early childhood services and systems to respond to what families want and need, to make services more equitable, and to really change the future, but it's going to take all of us working together to get there. David, I turn it back to you.
Thanks so much, Kay. Fabulous. Now, let's turn back to the state leadership report at hand and bring in additional critical perspectives and voices to further illuminate this work. Let me introduce you to today's dialogue participants from our policy team. Karen Howard, founding partner of Crossover Partners, with decades of experience in early childhood policy. She is previously a policy director at the Alliance for Early Success, where she led a portfolio of state and national partnerships and investments focused on home visiting, child welfare, family economic stability, and racially equitable policies for young children and their families. Karen is also a member of our Nurture Connections Steering Committee. And Geoff Nagle is another co-author of Nurture Connections State Leadership Report. He's an adjunct associate professor in the Department of Psychiatry at Tulane. He has dedicated his career to working on behalf of young children and families and supporting nonprofits to achieve their mission. And then Elisabeth Burak is a senior fellow at Georgetown University's McCourt School of Public Policy's Center for Children and Families, where she leads CCF's projects on Medicaid's role in supporting early childhood development and maternal health. So it's great to have you. So let's get started. Could each of you share what was particularly important and striking to you in this state leadership report? Karen, do you want to start?
I'd love to. Thank you, David. Well, I'm a federal girl, right? I do federal policy, and policymakers always say that states are the incubators of policy and of innovation. And what I loved about the report is it had a constellation of policies, anti-racist policies that taken together, and a broad range of policies, so that it dispels the notion that there's a silver bullet, and sometimes policymakers like to make a silver bullet. But it has a range of policies, from child tax credit to paid leave to economic to wages, and covers the waterfront really, and shows and gives a roadmap for how it could be done. And so provides policymakers that want to pick up different strands, or that want to do multiple ones, which I hope that they will, on how they could do it. And it has proof positive that it's working and that states are working it out. Because many times we have policies that are not implemented well in states, or they don't work because we haven't tested it out in states. We haven't included the community. We haven't included families. We haven't included providers. And so I really love the roadmap, and I want to commend Kay and Geoff for doing it, and for you for doing it, because I keep saying, show me, tell me. And it answers that. So that's what I like about it.
Great, Karen. That's a great start. Geoff, let me turn to you. Same question. What jumps out to you as you went through this journey together with us?
Sure. Thanks, David. And good afternoon, everyone. It was certainly, a very unique experience to do this report, because I got to talk to so many states. And what I really was struck with was how the public and private sector leaders are really partnering to advance policies that promote early relational health. The report is riddled with great examples. So if you have time, we hope you look at it. But I was particularly struck with the cross-sector work in New Jersey. Yeah. The Office of the First Lady, the New Jersey Department of Children and Families, multiple departments really throughout state government, the Burke Foundation, and the New Jersey chapter of the American Academy of Pediatrics, just to name a few, which really have been, working together to advance this work. And so some of their incredible achievements include an initiative called Nurture New Jersey, which launched in 2019, which is really focused on making New Jersey an equitable place, or the most equitable place in the nation to give birth and raise a baby. That initiative has led to over 44 pieces of legislation that have passed in support of that work. These groups worked together in May of 2022 to host a statewide early relational health summit, with that very explicit intentional name. And that, again, was hosted by the New Jersey Department of Children and Family Services, the New Jersey American Academy of Pediatric chapter, the Burke Foundation, and had sponsorship as well with the SPAN Parent Advocacy Network and the Terrell Fund. And the participants at that, I think, is very interesting, because they drew families, they drew pediatricians, childcare providers, nurses, social workers, community health workers, doulas, home visitors, and, just the wide range of professionals who work with young children. And that, was some of the point that Kay was making in the overview, is that how this really touches the work that we all do, regardless of our background or discipline. It really does, boil down to early relational health. And I think, especially with the initiatives in New Jersey, a lot of credit goes to the Burke Foundation. So again, the private sector really acting as a catalyst to a lot of this work, and obviously very willing partners. So it takes everybody, it takes the village, but I think it's a really great example in New Jersey of how the public and private really work together.
Geoff, that's such a great example of network weaving that goes right on down first to state and then down into local communities and then back up. And so that's a great example. Elisabeth, to you, what's inspired you about the report, first blush?
Well, first, thank you for having me. I think what inspires me about the report is the same reason I'm here, which is I am thrilled that the health system and Medicaid is represented in this conversation. And on one hand, I think a lot of times in, a lot of the traditional early childhood groups, or even early relational health, we tend to think of the health system as a very different system. And yet, I think we do the work we do, and others, of course, like you all, because Medicaid is a major funder of health coverage for kids. It's not seen as a kids program, but it really essentially is a kids program. More than half the kids in the United States are on Medicaid or CHIP, particularly recently. And the vast majority of low-income kids are in Medicaid and CHIP, and most births in this country, close to half, depending on the statistics you look at, are paid for by Medicaid. And while it has been an exceptionally great program to drive the rate of uninsured kids downward over time, and been a major player, we know coverage, first of all, we can't take for granted for the reasons Kay mentioned. We have a lot of kids who are dropping off of it right now for procedural reasons. But more importantly, we know that coverage has to mean something. And we have a lot more work to do to realize the potential of Medicaid, and particularly benefits for children and moms. And what is great about this report is that we see these examples of the many different ways. There's a lot of state flexibility in how Medicaid's run, and the different ways states can try to really better understand what are the benefits that need to be in place, whether it's primary pediatric behavioral health care in California, or community health workers in other states. I think there's a lot. This report helps to showcase the kind of things Medicaid can do. And I'll say it can't do everything. We need to look at other things too. But to be part of this larger bucket and conversation is really important, because frankly, we need to start holding those Medicaid dollars accountable.
Oh, what a great start. Thank you. Let's go a little deeper. One of our major strategies is thinking about workforce. And what in the state leadership report do you think supports advancing our relational health workforce? Geoff, can I come to you first?
Sure. There's just really encouraging and exciting advances in that area. Certainly Michigan's systems level work with a focus on prevention, building the overall knowledge of the early childhood workforce and early relational health and infant mental health, and the availability of infant mental health treatment using clinicians who have the infant mental health endorsement. That's a great example. And again, just to, come back to New Jersey, to promote early relational health, the state created the Professional Formation Center for the Early Relational Health Workforce at Montclair State University's Center for Autism and Early Childhood Mental Health. And this Professional Formation Center has developed a training called Keeping Babies and Children in Mind, which provides professional education and evidence-based practices, including topics on promoting early relational health and infant and early childhood mental health, supporting child and family strengths, and responding to trauma. Now, what's really interesting is that these multidisciplinary trainings, of which they have multiple departments represented, multiple employees of various areas of the public sector, this training has been provided to more than 20,000 professionals in the state from the whole range of public services and systems. So training these different, training people from different systems together really helps to ensure that wherever the family goes, whoever they encounter in the system, they're going to be talking to someone who has that same base knowledge, that same base training, which is, I think, really unique and fantastic. And for other states that are interested, that training is available to other states and is currently being shared with other states. And there are many other examples in New Jersey, to embed early relational health principles in pediatric practices. The New Jersey AAP and the Department of Children and Families, along with the Burke Foundation, brought the Keystones of Development, which is an online curriculum for training pediatricians. They brought that to all 9 residency programs in the state, as well as to the 12 family medicine residency programs that exist. So all the physicians in those programs are getting that same opportunity for that training. So there's many other efforts that are highlighted in the report, but I think there's a lot of great work going on that can really, if your state is interested in doing that, there's great examples out there to follow.
Geoff, those are all examples of remembering that nurture connection happens at the level of the relationships and within communities and all those various actors that touch families' lives. Having a relational frame, a deep respect and strength of recognizing this assets of families, all of that is within this workforce development effort. Karen, how about you? Your thoughts about what the report suggests about advancing relational health workforce?
Everything you said, and everything Geoff said, if we're going to embrace the wisdom of communities, particularly communities of color, we have to really lift up community-based services, which are provided by mostly women of color. That is the workforce. And I am so glad about community health workers and doulas and peer-to-peer specialists that now states, New Jersey, California in particular, which recently passed their doula and community health worker benefit under Medi-Cal, that they're really embracing that workforce and trying to figure out how not that they could change them to fit into a financing system, right? Because the system is flawed and kept them out for so long, but how the system has to change to support this workforce, to nurture it so that it is relational, and how to provide adequate financing and training. And what I love is that they're doing it with community health workers and doulas. They're doing it with peer specialists and others, and not presuming what will work. And that's really the key to this. They hold the relational health and the relation and spreading that and infusing it within the system. You start to change the system, right? That has cracks and has been flawed from the beginning. It's not been easy. I think the report really highlights that there are real challenges to how you do this. How do you make a provider, a community provider, a Medicaid provider? Very difficult to do. But there's a real recognition in California and other states that we're going to sit down and figure this out, and we're going to do it holistically. And there's a willingness on behalf of the government to partner and have a strong feedback loop, but really co-design more than a feedback loop. A feedback loop is tell me what you think. A co-design is how does the system need to work? And so that's really exciting. One thing I hope happens, because I don't understand why doulas go for Medicaid and then community health workers and then home visitors and then peer, they're really in the same boat. And so I would love to see locking of the arms, facilitation of having private-public partnerships that really facilitate. And I always say this, right? Collaboration is an unnatural act between unconsenting adults, but it really isn't. We really do need to come together. And I think this report paves the way and at least shows that there is the beginnings of that. And that's really exciting. And so I'll say that.
Karen, beautiful. It reminds me that Charlie Brunner and the Ink Marks and Kay Johnson and others started talking about the relational health workforce as being all those people that touch families' lives and realizing
Right.
they come deep out of communities and they represent the family's experience and the lived experiences, and helps move the equity journey too within the workforce development strategy, and can also build the strengths and assets of community as a community building strategy
Yeah.
That's a really powerful
And
message.
David, one of the things I'll say for the community health workers in California, a requirement was that they have the lived experience of the community, built into the system. This is a way that these community narratives that are so powerful can start to infuse and change mindsets of people, right? It really is, it starts there. This is quintessentially an anti-racist policy. And as it's taking hold in different states and different contexts, it is fascinating to see how it's working, what works in New Mexico or what works in California or New Jersey. But there's a real movement out there. I also think, and I will stop in a minute because I want to hear from my colleagues, that we have to break down on what we see as evidence-based policy that excludes the community, that devalues the wisdom and their knowledge of what is healing and what needs to happen, right? And we need to expand that into practice-based evidence. Families know what they want and need. And they want relational. They want, they want their community and their community narratives and the people, and they want a village. And a village can support this, and a village can harm it too. And so what we're seeing is the village is really coming together to support this.
Beautiful, as we see that same emergence of the policies based in Washington State with the community health workers into the medical homes. The power of voices and lived experience of community health workers coming out of the community into the clinical practice is transforming those practices by those relationships within the medical home itself to become more equitable, more conscious of the strengths of families and the relationship that can be built by the community health worker to build trust into the high-performing medical home. It's really part of that movement making with a relational frame.
It is powerful.
Elisabeth, we're going to come to you now. Your turn.
I would just like to lodge a formal complaint for having to follow Karen Howard on this.
Oh, no.
Ditto. And I think that I'll just reemphasize something Karen said that I think is really important. The medical billing complex has not traditionally been particularly good at thinking about how to help community-based organizations that aren't clinics or don't know what ICD codes are. I don't either. In terms of paying, doing paying. And that's fine. That's understandable historically. But I think if health systems are serious, and they are right now because of maternal health crisis and all the things that we are finally looking at, if health systems, and particularly Medicaid, are serious about addressing health equity, they have to look at the community-based workforce, because that's where the evidence is. We are able to figure out how to build trust with communities of color that have been historically marginalized from the health system and figure out how to engage them and support them. And it is great to see all these states taking up doulas and community health workers. I would add that it's an opportunity to think about home visiting and other similar, as Karen was saying, groups that have had a hard time really figuring out how to navigate the billing minefield. But I think there's an openness to it in ways that really hasn't been in a long time, because it's just, we have to think differently about it. So I think that's a real opportunity. And I would also say, and I think Melinda put this in the chat, we were fortunate to host a conversation with many experts, including Kay and David on this call, pediatricians, OBGYNs, and other practitioners, and Medicaid experts in a meeting in October, where we just tried to understand, all right, we know most states are expanding postpartum coverage. We know that's a critical year of opportunity for young kids and moms in particular. How do we think about Medicaid's role in making sure that year does what it's supposed to, generally for the relationship and for each of them individually, but specifically in mental health, because mental health has been even more overlooked generally for this population and in the health system. So our report, which I think we'll put in the chat, kind of outlines what we think is sort of the Medicaid opportunities. And the one that I think was overwhelmingly supported was this notion of a community-based workforce, really having doulas, community health workers, and others that can help make these links. And Kay Matthews, who is the executive director of Shades of Blue in Houston, I said it more eloquently than I'm about to, but she said, we have to turn the workforce upside down. Yes. We have to flip what we know about how we serve families. And I was just I felt like that was a really great way of putting it, because we're not going to get there if we don't. And I think this relational health training and infrastructure and opportunity is built into all of that. So I should also add, and I meant to add at the beginning, but I was so inspired by Karen's points, Medicaid as a general rule isn't going to change the workforce problems we have, right? There are a lot of things it can do with payment. It's not going to fix them, but this is one very specific area where we're seeing Medicaid do more. And I think we should encourage and promote that as much as possible for young kids and parents.
Elizabeth, that's fabulous. And my gosh, wasn't that gathering amazing that you hosted, and the opportunity, really thinking that postnatal period, that first year, and the opportunities that this brings. So we've been talking about the high-performing medical home. Let me bring you all to the next question. Nurture Connections Early Relational Health Policy Agenda includes an emphasis on high-performing medical home, or an accessible, family-centered approach to providing comprehensive and high-quality primary care. How do you think federal and state policy can incentivize advanced team-based, high-performing medical home care with relational care as its center, and coordination, and including models embedded in primary care? Geoff, let me come to you, then I'll go to Karen, and now I'll go to Elisabeth, then I'll go to Karen to change it up a little bit, okay? So Geoff, you're up.
Okay, sure. Well, there are several examples highlighted in the report, and I'll just mention two of them here. Certainly in Vermont, they've made a big commitment and invested in the model Dulce, which they've been doing since 2017, and they're working to really ingrain that model statewide. It's administered by the state's Family and Child Health Program and currently has 6 pediatric practices, but that's, it's Vermont, so that's larger than that sounds. And they're working to get that, all around the state. And then in Washington State, and this was, I think, alluded to in the chat from one of the pediatricians who's on the call, but in 2002, aiming to advance early relational health in these high-performing medical homes and improve children's mental health, various state-sponsored steering committees and work groups, they made several recommendations to the legislature regarding Medicaid financing for community health workers in pediatric primary care. And this led to legislation that directed Medicaid to create a grant program to embed these community health workers in primary care as an integrated part of the care, working with children and families. And I think that's going very well, as we talked about in the report. But again, in the chat, while on this call, you see a pediatrician really kind of speaking to that, how powerful that is, and really making that part of an integrated multidisciplinary team. So I think it's a huge part of where we're headed, and is a very, for a lot of the things we're talking about today may seem less concrete because they may not have early relational health in the name, but certainly working to create high-performing medical homes is something very concrete that a lot of states can really dig their teeth into. That's
great, Geoff. Elisabeth, back to you.
I love this one because this is something Medicaid absolutely can do, and it can do it right now, right? This is like right in Medicaid's wheelhouse. It's where the health system can play a role. And I think this is, folks on this call will know this, but Medicaid is the broadest place to reach low-income families before they get to kindergarten. Until we get universal childcare that I'm sure we all want. But I think that is a really important place to serve families. So that's why all these models like Healthy Steps and Dulce and others are really being more promoted. And I think that, again, for a variety of reasons, the health system's not set up to be a prevention system, but Medicaid and health plans and others can rearrange payments to make sure that they're paying for team-based care and all the kinds of things we know these models need to be successful. It can't just be one doctor and one nurse and screenings and making sure, sending families on their way. So I think this idea of having this hub, particularly for kids and their families with an early relational bent, it just makes sense, right? This is what we want primary care to be, and what I think Medicaid and health systems like to have primary care and folks connected to a medical home. So this just makes sense. I think states can do it now. There are federal things that could happen to incentivize this kind of thing, but there's nothing to say states can't do it, even just in the context of their managed care contracts right now. So I think we're going to see more of that, particularly as states start to be, CMS is starting to look at states and how they're implementing the pediatric benefit and EPSDT across the country. So I think this is an opportunity to think about that connection too.
Yeah, and David, I'll just say, I want to echo what Geoff and Elisabeth have said. I think funding the Transforming Pediatrics for Early Childhood and having more incentives for cross-sector collaboration would be great. I want to see housing. Housing is healthcare, right, within a medical home. You want to see other supports. And so I want to echo what everybody said, but I think additional funding for programs like that would be ideal.
Okay, let me pull you in as one of the champions for high-performing medical home.
Yes, I
your
was
thoughts.
just going to say that. Thank you, David. As you know, I've been thinking about this for a number of years, and sort of came to it thinking about a grassroots up. What were exemplary practices that were going on in pediatric primary care for young children, and through the work of Charlie Brunner and the work I did with him with ink marks of gathering up those examples and asking those practices, what do you need? How do you do this? What is it that you consider exemplary about what you're doing? Talking to the various models, the evidence-informed models that were being recommended to be embedded in pediatric primary care, and then working with states on their Medicaid policy. So states were sort of picking it off. Let's get this model funded. Let's make sure we get developmental screening funded. Could we fund Reach Out and Read? I mean, could we get this other screen here? Could we get a community health worker? That doesn't make sense in today's healthcare world. This is a big bundle, people. It's a bundle that says we're going to do a better job at the well child visit so it follows bright futures. It engages families in a respectful way. We're going to have relational care coordination for those more intensive social and medical needs, really connecting people to the community resources, really closing that referral feedback loop. And we're going to embed models appropriately and do things like integrated behavioral health, and then really getting people connected to home visiting or to Part C early intervention or to the dentist starting at age 1 is recommended in the Medicaid program. So you've got all these pieces. Let's bundle them together. Let's stop infighting about whether it's this model or that model or a health worker or an integrated behavioral health, and say that we ought to be paying for this, that this is effective, and that we have the evidence that this broader team-based approach can be effective, and it's a really critical investment. Ask Medicaid to pay for it as a value-based bundle and get the job done. As Elisabeth said, it could be done in any state. Massachusetts is on the cutting edge of this, but there are other states looking at it, and there are opportunities across the country. And as important as it is, I think, I'm going to stop in a moment, that, somebody does a community health worker demonstration, California gets doulas and models and community health. Let's go get them to pay for the bundle so that the practices can do the work. Last but not least, 151 community health centers have grant funding to advance early childhood development. And a lot of people talk about it like it's just, well, let's get them to do a developmental screen and let's refer them to Part C if they have a problem. Let's get them to be high-performing medical homes for young children. They're already doing so many of the pieces. It's not really too big of a stretch. I'll stop.
The vision is good. The vision is right there. The vision can be operationalized, which is so exciting. Okay, the last question I'll bring before we close, for the last 5 minutes of our discussion, what's the opportunity in the policy space to elevate parent and family lived experience to further health equity, which is a core value of all of our nurture connection relational health work. Karen, let me come to you, then we'll go to Elisabeth, Geoff, and then Kay.
So I want to, of course, I'm going to talk about the child tax credit, right, and economic policies. And if the pandemic taught us anything, it is that the child tax credit cut poverty in half, and that people would say, we don't know, the poor will always be with us. We don't know what to do about poverty. Well, we do know what to do about poverty. And we saw, right, that families use that money, use those resources on rent and on food and on early childhood supports on their family to get a job. And so there's an opportunity, right, that it is coming back around, and it is coming back around in a bipartisan way. In Congress right now, considering an enhanced child tax credit. It is not as robust as it was during the pandemic, but it is bipartisan. Republicans like it because it supports families. It supports families having children, something that they are very much interested in it. Democrats love it. And so it is not a sure thing. And so one of the things I'm going to ask is folks to please contact you. You have a chance now. This new tax credit has the impact on 16 million poor children living in poverty. And you have the chance to amplify their voices and join their voices. And I would really encourage folks, and I know we're dropping it in the chat, information from the Center on Budget and Policy Priorities, as well as First Focus on how you can engage on the child tax credit. So with that, thank you.
Oh, that's so exciting, Karen. Thanks for your leadership reminder here. Geoff, your thoughts about the policy space and elevating family lived experience?
Yeah, I mean, I think it's really critical, and we see it as more and more powerful as the months go on. I mean, we need to motivate policymakers to adopt multiple policies, right? This isn't about just one program or one service. It's multiple, and that's what this report really captures, is the comprehensive nature of what is really needed to support parent caregiver efforts to nurture their infants and young children. So this includes an array of policies that support family economic security, recognize the need for families to spend time with their children, promote early relational health with access to high-performing medical homes, high-quality early care and education programs, the continuum of home visiting programs, early childhood mental health services, family support programs, community-based workforce. It really is about a comprehensive agenda to support young children and families. And I think the way to get us there and out of the very single lane highways that we usually are on is to bring the parent's voice into it. And if we do that, I think we can see greater change in a shorter timeline, which is always what the frustration is for all of us, how long it takes to see any progress.
Elisabeth.
Yeah, I think we're all trying to do a better and more thoughtful job at this for all the reasons everyone said. And I think for me, a lot of times the role of state children's advocates are really there to help bridge some of these policy conversations, and even more so in the last few years. Folks at NC Child and others have really tried to build up capacity and support ongoing sort of family engagement and sort of councils that are not just performative. They are really sort of trying to get them engaged and train them up in an advocacy space. That's one thing. But I also think we haven't talked about the role of state advocates. And I think about all the states in this report. I don't think any of them haven't had, at some level, whether it was out front or behind the scenes, state child advocates or health consumer advocates or others who were helping to set the table. And I think it's been really important too, as we think about all these different systems and bringing them together. And I'm just going to call Kate Breslin out because I know she's on this webinar, who is the head of the Schuyler Center in New York. And she was, as the state was looking at Medicaid reforms a number of years ago and delivery system reform, she came to those tables and said, we need to make sure we are putting payment reforms in healthcare that do not put adult reforms onto the developmental needs of children. We want to make sure we are really thinking about that. And that brought out the first 1,000 days of Medicaid initiative in New York. So I think advocates can really help to be a link between what families need and across all these systems. And I think are really often, they don't always get the public attention, but are often really big drivers of these as well.
Was this such a strong point? Now I'm going to call to each of you the challenge of a 1-minute closing point that you'd like to leave the audience with as we're rounding out towards the close of our little webinar. Kay, can I come to you? Then Geoff?
Absolutely.
All right, Kay, go ahead.
So my one point here, and that's when I worked for Marian Wright Edelman at the Children's Defense Fund, she used to make us write a list that said, what can one do? What can one doctor do? What can one advocate do? What can one government official do? What can one child welfare worker do? What can one do? You're one. Everybody on this webinar is one. When you leave this webinar, figure out what your one, you as a person, can do with others, as an individual, in your role, where you are. There's something you can do to make a difference in this, and that's how we're going to get there.
Beautiful, Kay. Thanks. Geoff, to you.
Yeah, I mean, I think I was really struck by the role of philanthropy in catalyzing and stimulating this work and approach. I had mentioned the Burke Foundation in New Jersey. Another example is the Perigee Fund in Washington State. They funded dedicated positions in the state Medicaid agency to advance early relational health. And these, those people they funded, those subject matter experts in early relational health and infant and early childhood mental health, they participated in the co-development and implementation of a variety of initiatives that are advancing early relational health and infant and early childhood mental health to support positive outcomes during pregnancy, postpartum, infancy, and early childhood. So really this public-private initiative between Medicaid, the Medicaid agency, private philanthropy has really proven to be a very powerful lever to advance early relational health. And so I would really call that out to many states as a great example of the many opportunities that are out there as detailed in the report.
Here, Geoff. That's a really good one too. And Elisabeth, to you.
So I've been really focused on, we have all but 4 states that have adopted this postpartum extension to 12 months for all pregnant women. And I think while we have the attention on this and the maternal health, the importance of maternal health, we have an opportunity to help states think about what does that year need to look like to promote early relational health for mom and the baby. And while we need to look beyond that year, of course, I think that we have a really important window of opportunity to focus state health systems right in that year.
Great. And Karen, you want to round us out?
Yes, I'm just going to take an analogy that I saw in a movie I recently saw, Origin, and a book, Caste, in which it talks about our very flawed racist caste systems that we have in this country. It analogizes it to an old house, right? And the basement is flooded and the foundation is cracked. And we didn't build that house, but we live in it now, right? And it's on our watch. And what we do to shore up those foundations, what we do to change the foundations of it and rearrange this old house, it's on your watch, that children and families and all of our watch, right? And so it's really a plea that we each can do something. And I'm going to ask that you, again, it's an election year and most of the politicians in state and federal are running for their job. And I want you to hold them accountable, as you always have. I want you to reach out to them and make sure that they know early relational health is the basis, whether it's the environment, because early relational health shows up there, or transportation, healthcare, early childhood. Hold them accountable for the house we want to live in and the house we want to see. So, and I'll be right there with you.
What an amazing panel. Thank you, my friends. Let me finish us up. Now's the time to partner with families, providers, and communities to strengthen early relational health, the time to advance equity by adopting and implementing these effective policies. Please read our report on our website, stay in touch with us, sign up for our newsletter. I think that link was dropped in the chat. And if you're not already part of our network, join us as you continue to learn, as we learn, and as this work grows. Thank you again for joining us today. Blessings to you all. Thanks.